I think everyone who does. My name is Candace. So I am the one who you guys have been corresponding with for the past 2 years in some capacity, whether it's email, phone, coaching call, webinar. But it's really amazing actually to see most of you here. Some people I've kind of looked at and I was like, oh my God, I recognize you and you're in person and I'm in person. And that's been a strange thing for the last 2 years. And then hopefully you guys recognize each other and have already connected in some capacity from the beginning. We'll be here, for the next few hours and tomorrow. So welcome to the Breakout Room 3 general session, incorporating families into MAT care. We just wanted to start off, make sure you're present. We will have time to answer questions a little bit towards the end. So allowing Josh to present himself, and then of course, hold your questions towards the end, where we'll have a normal Q&A session. So before we begin, I would like to introduce Josh Clark. I think some of you already know him from various groups, coaching calls, breakouts, but he is an alcohol drug studies specialist as well as a certified alcohol and drug counselor. He has been on his career path since 2008, has multiple years in leadership before coming into position at Marshall Cares, which he has been at since 2018. Before that, he was the program manager for a local withdrawal management program in the community. And he has been the program manager for Marshall since 2018. He is also a person with lived experience, open recovery, and has been in recovery since 2008. And he will present again on incorporating families into MAT care.
All right, thank you. Thank you for introducing me. Hi everyone, I'm Josh. And so that's the title, incorporating families into MAT care. Why, when, how, who, and who pays. And that's the kind of, those are the pieces that we will talk about today in that order. So I don't have anything to disclose. I'm not getting paid or anything like that. This month is National Recovery Month. I love this. Recovery is for everyone, every person, every family, every community. And so each September Recovery Month works to promote and support new evidence-based treatment and recovery practices, the emergence of a strong and proud recovery community, and the dedication of service providers and community members across the nation who make recovery in all its forms possible. Yay, I love that. That's great. And so we're going to get right to it, talking about how to incorporate families into MAT care, the why, when, who, how, and who pays. I already said I don't have any financial disclosures to report, but I do want to say that the majority of the evidence around this conversation was taken from the SAMHSA tip 39. And so really great place to find evidence-based stuff. And so the majority of really like kind of all of the things that sound, oh, is that evidence-based? That's where it came from. So just if anybody at the end of this is like, you'll see a slide at the end of this where it says we just are scratching the surface. My challenge to you would be to go to that tip and learn all about it, because there's no way we can fit it all in just an hour. So why do we want to incorporate families into MAT care? Let me get to my little thing. Incorporating families into MAT care is evidence-based, an intervention that helps people improve their health and wellness around substance use. Families are these complex systems, and it's a system that will try to keep its equilibrium or homeostasis. And when substance misuse occurs, family members try to manage the behavior of that person that's using drugs, and the consequence of that use for the family. And a family can go through a wide range of responses, and we may on the outside look at some of those and say, are those enabling, counterproductive? What is there codependency? But all of those kind of family reactions really serve a purpose, and that's to keep the family system operating. And that family system and how it operates can really directly influence treatment engagement, treatment outcomes, use of support systems, and sustained recovery for family members. And one of the things that to really recognize is that the majority of substance use disorder treatments have all really, the focus has always kind of been on the individual. And so one of the whys is really to involve families. When we involve families, we create this thing called recovery capital. Right. And having family members be able to understand this is what that looks like. This is what medication assisted treatment. This is what the evidence looks like. These are these principles of recovery. These are these tools that families can use to help support the person that is pursuing change in their life, right? And so often family counseling is viewed as something that maybe not be as important as the individual counseling, and that can really send a negative message to families that they maybe don't have any kind of traction to be able to actually be helpful, right? And so by integrating family members into treatment, it gives people, it empowers people, and also really helps individuals be able to call on family members to be supportive. And so the challenge, I think right now, before we go on, is to really think of what are your attitudes and beliefs around family? And what do you think about involving families in treatment? Do you have any kind of biases from your own families? And really being able to connect to those things that my family is going to look different than yours, your family is going to look different, and to really be mindful of those kinds of biases, and knowing that integrating family-based interventions can really be a very, very valuable and primary part of substance use disorder treatment. And so let's go to the next slide. So anyway, integrating family counseling into SUD treatment can really leverage the important role that families play in helping their families change their substance use. And often with new insights and new coping skills, family members can create an environment, a family environment that supports recovery for every family member. And so the benefits of incorporating families include improved treatment engagement, prevention, motivation, something that's really important, cultural responsiveness. My culture of my family is going to be different than yours, and often incorporating cultural responsiveness can really connect people to things that are motivating them. It can give new perspectives for family members. Improves family functioning, can help with relapse prevention, reduce stigma, and creates recovery capital for people with substance use disorders. And overall, it improves all outcomes. And let's go next. So when do we want to engage families? I think that families, and what the evidence says is that families can really be engaged at any time during treatment. And I think it is really important to build a relationship of trust with your participant or client or patient, whatever they are at your place, before engaging family members. Help participants understand what family interventions look like in advance. So don't bring somebody in and then ambush them with the family, right? No ambushing. And really kind of important for the participant to really say, hey, this is important to me, because then they're invested in their family coming, and really, it is always best for the participant to be like, this service is of value to me. And so there are some potentially tricky parts of being open and saying, yeah, we help families here. because then family members will call, right? And say, what happens there? What do you do? What's going on with my family member? And so we have to be mindful that CFR 42 Part B still exists, and that our participants have right to their confidentiality, and they may not want all of their family members to know what's going on. So it's always, we want to always enlist our participants in their own treatment to connect with their families. And so what we do is when families call and there's not a release of information in place, or the family member the participant didn't request it, is we will talk about what we do in really general terms. We'll explain CFR 42, explain why that matters, talk about what we do as a program, but never give up any kind of information about the participant, right? Because they have the right for that information to be protected. So we should be mindful of that. And so also something else to be mindful of is that families really benefit from low barrier, low threshold access to understanding Matt, really benefit from creating a relationship and feeling like, oh, at Marshall Cares, Josh is that person that I can go to understand, right? Josh is that person that I trust, or it's not always me, right? That is the person that I've worked with, that I have a relationship with. And so just like it is important to, crucial to really develop those relationships with our participants, if we are going to involve their families, we should be working to develop those same kind of relationships. And just like low barrier, low threshold access works for our participants, guess what? It works for families as well. And so what we try to do is really have no wrong door. And so with our participants and with family members and with our community, right, of how we interact with people, really no wrong way to come to us to get information. And then, right, so who, I think that this part is that part where understanding what we think of family might be different than the next person thinks of family, and really allowing people to, the participants, to be able to say, this is what family looks like for me. These are the people in my life that are going to be supportive and play the role of family for me. Because it's not always, mom and dad. It's not always that. It's not always, it's often grandparents, loved ones, aunts, uncles, families of origin, all different kinds of things where people may consider that to be family. So I think it is important for our participants to be able to say, these are the family members that we want to participate in our treatment. And so I think what we can do is create a safe space that encourages family members to discuss challenging topics. And just as it is important to create trust in our relationships with our participants, it is equally important to create those same types of trusting relationships with family members that are participating in treatment. It is valuable to connect with our participants, to have a family of understanding of family dynamics, of their family dynamics, or how they perceive their family dynamics before we have the families come, right? That way we're not ambushed with stuff that might be wonky, you know what I mean? And so this will help to understand of who should be included, but maybe also just as important, who should not be included. And so circumstances where family members should not be included can really be equally as important as who should be included. Meaning that, like, situations where there's been intimate partner violence, child abuse, neglect, if family members themselves are currently withdrawing from substances, might not be a time to have a family meeting. If family members are struggling with mental health, psychosis, suicidal ideations, those might be times where we don't include family members in treatment. So let's keep going. This is the part that I think might be my favorite. And that's the how. So what we do at Marshall Cares is we really work to create a space for families to come and participate. We have a thing, we call it Family Friday, and we block out 2 hours every Friday. And it's not like we invite your family, your family, your family, your family. It's one family, right? Right. I think that's important to be like, hey, we're going to have your family come, not a bunch of different families. And then what we do is we start by talking about all of the evidence-based treatment practices that we do at Marshall Cares. Letting the family know, hey, this is what this looks like. This is what the evidence says. This is what the evidence says around medications. This is what the evidence says for this substance use disorder or this substance use disorder, making it really relevant for the participant's family. Like if a family member is coming and seeking treatment for opioid use disorder, we might not tell them all the evidence around alcohol use, right? We're gonna tell them the evidence around what is happening for their participant. And then we do this thing where we present the neurobiology of addiction, the disease model. And we show what happens when someone's brain, when that thing turns on. And how extended dopamine release creates that compulsion to have that dopamine release, and how that compulsion really how addiction is a disease of choice. And it really helps people say, oh, I understand what's going on now, right? I understand that my family member really loves me, but that this compulsion is driving them. And then we really talk about strategies of how to get the prefrontal cortex into the driver's seat, that part that can really make higher cognitive functional decisions, right? And how making recovery plans and routines and holding people and accountability and all of those things can really help people move through change around their substance use. And we really try to use a harm reduction approach to that conversation. And so it works really well. And families often will have a wealth of questions around boundaries and codependency and ways that they can help their loved ones in the recovery process. And so the Family Friday really creates this relationship. And what happens is not only does the participant trust us, but now the family trusts us and trust that there's evidence around our interventions. Trust that what we are trying to help people around their substance use, that those things actually work. And what that does is that creates recovery capital, not just for the participant, but for the family, right? And gives hope. Man, hope is a really powerful thing, right? And so if you are a person that's using drugs and your family doesn't have any hope, then that's not really a source for you to be able to go and find that thing, right? And what we discover is that by integrating families into the process, that hope factor really starts to grow. That recovery capital factor really starts to grow. And then family members can be like, oh, okay, you're going to Marshall Cares. Did you make your Marshall Cares appointment? Right. And it really can really start to change the stigma that people may have around their loved one's substance use, and can really change the pathway for people that are using drugs. And so we use motivational interviewing. Really, really important to respect a family's right to their own autonomy and to be able to guide themselves. I think one of the things that we also really do that's really, really great is we look at all of the outside community resources in our area, all the ones that might benefit families in our area, and then we provide those resources. And some of it's like, the Al-Anon stuff, that stuff. And then some of it is stuff that's outside of the box, whatever the family thinks. If I was connected to this, same things for our participants. If I was connected to this, it would improve my health and wellness. If I was connected to this, it would improve the health and wellness of my family. Okay, let's find that for you. Let's do that. Let's find that thing. So that's what we do at Marshall Cares. And let's see, where am I? Oh yeah, here we go. So the number one thing that we do at Marshall Cares is this one, the psychoeducation, presenting the disease model, which is psychoeducation, and presenting cognitive behavioral interventions and what those look like, and how the disease model and those interventions, how the evidence really ties those things together. And so psychoeducation is really widely used approach to family-based substance use disorder treatment. And many families can improve their functioning and dynamics simply by learning about drug and alcohol addiction and recovery. Lots of times families come in and they're at this place where they really don't know what that looks like. They know that what's going on with their loved one is not what they want to be going on with their loved one, but they don't know anything about any of the solutions. We often hear the thing of like, isn't buprenorphine just replacing one thing for the other? Right? We hear that all the time. In the disease model presentation, I really like to talk about the compulsion to eat food, right? The craving to eat, we call that hunger, right? Family members go, oh yeah, I know what that is, right? And really say, well, what would happen if someone was starving to death? What are the worst things that people might do if they're starving to death? Right? And family members are able to really connect to that idea. And then I say, what if you gave that person a sandwich? Right? And then the next day you gave them a sandwich, and the next day you gave them a sandwich. All of a sudden, that compulsion in the midbrain, that thing that's driving you to get food no matter what, all of a sudden that's gone, and you're able to really think critically about your decisions again because you're not starving to death. And I really love to really say, well, buprenorphine is that sandwich for opioid use disorder, or methadone is that sandwich for opioid use. Where I work, we use buprenorphine, but that medication is really that sandwich, and really allowing the prefrontal cortex to get back into the driver's seat. And so that really works really well. We're going to go over a whole bunch of these, and this was really taken from tip 39. If you want to learn more about these interventions, go to tip 39 and read more about them. And also, I think it's important to be able to say, what do we do at our clinic or facility? What is in our scope of practice? And what are we really going to be the best at to be able to use these different treatment modalities to be able to help families. And so multidimensional family therapy has good evidence for reducing substance use disorders, especially among adolescents. And it addresses individual behaviors and family processes, improving functioning among adolescents, parents, families as a whole, and family relationships within their communities. Behavioral couples and family counseling approaches help support recovery by teaching people to improve the quality of their relationships, engage in healthier communication, and build positive relationships with one another. BSFT, or brief strategic Therapy uses a problem-focused, practical approach to reduce or eliminate youth substance misuse and enhance family functioning. FFT, functioning family therapy, takes a problem-solving approach to engaging, motivating, and creating behavior change among clients. Families are also taught how to apply their newfound skills in future situations. Solution-focused brief therapy invites families to build a positive vision of their future and identify interpersonal changes and improvements in target behaviors needed to make that vision a reality. Network therapy uses a combination of individual and group therapy approaches involving members of clients' network of supportive family members and friends in sessions. The main goal is for members of the supportive network to learn how they can reinforce the person's efforts to achieve and maintain abstinence. So that one is a little abstinence based. I think that what is important is to be able to say, like, what are we going to do here that is going to work? What kind of clinicians do we have? Let's get them to work at their highest scope of practice and really apply whichever intervention that's evidence-based that's going to work in your location, right? Just because we do psychoeducation and that may be your facility or clinic or treatment place may have people that are able to work at a higher level, and if that's the case, then they should be. I think that offering other family-based skills and services can support recovery across the continuum of care, and that understanding different treatment approaches and offering family-based skills can support recovery across the continuum of care. And these could include engaging family in treatment, linking members to the community, providing mutual aid recovery supports, facilitating behavioral contracts or learning about boundaries between the person and the family and their family members. And then teaching problem solving, understanding relapse prevention, understanding harm reduction, really helping family members understand all those different treatment modalities. And so family-based treatment can really guide families in enhancing their thoughts and reactions around substance use. And that new understanding can really lead to major changes within the family as a whole. And so regardless of your approach, all family-based treatment shares certain core aspects. And really, the aspects are really about improving the health and well-being of the whole family, not just the person with the substance use. Respecting the value of family and other social relationships as a key part of recovery, and meeting harm reduction goals other than abstinence, which can still benefit or still will benefit the family and the individual. I kind of feel like I'm cruising right through this a little fast, actually. All right, so I think we just said that all family-based treatment shares certain core aspects, including improving the health and well-being of the whole family, not just the person with the substance misuse. And I think that we just said that. So now, who pays? This is really challenging because there's not a at least in California, there's not like a CPT code or a billing code that medical providers can use to say, yeah, this was a family, right? And so for most substance use treatment, billing options usually involve billing an individual's insurance for the provider visit, individual counseling, group counseling that don't include family members. There's really not a billing code that we can use that's like, oh yeah, we did family counseling today. And so insurances don't typically reimburse for family substance use disorder services. But I think here is the sell is that helping individuals and families initiate and sustain long-term recovery contributes to the overall health of communities and lowers societal healthcare costs. And so if we are working with our organizations, I personally work for a hospital. And so by saying, hey, we are going to engage families, maybe you're going to see that person less now in the emergency department. Right. And so lots of programs already involve families in their substance use treatment process in some way, such as through family psychoeducation groups. And that integrating family counseling into substance use disorder treatment can require administrators to make investments of time and resources. But the benefits to our participants and their families and communicate and our communities can really make those investments worthwhile. And so if you're trying to implement, incorporate families into your treatment, that might be the sell for your organization, right? Yeah, yes, we see that we can't bill for it, but by helping families understand this process, maybe we'll see people in the emergency rooms less. And so let's talk. Let's talk about it. What do we think? That went really fast. Yeah. Normally, I really like to have all this stuff memorized, but anyway.
We didn't have one from online.
Oh yeah.
Just since you asked it earlier on, it was about my questions related to resources for providing family-based interventions. What is the payment structure? This is asked for.
Yeah, so I think that we just covered that. Really, the challenges and maybe we can drive change is that there really isn't a way. There isn't a billing code for like there isn't a Medi-Cal code for family substance use treatment.
What if you use a collateral code? That's it is a drug Medi-Cal revenue code for doing a service with anybody significant in the person's life, i.e. family members. So there was
I didn't know about that. Maybe me and you can connect and we can talk about that collateral code. Yeah. I'm glad. Yay. All right. Yes.
Thank you very much.
Yeah.
So back to your last question, which is pretty much why we're all here, which is paid or whatever it is, the nature of the beast. So the family member, I work for FQHC, which is a federally funded space, and several family members are at the same clinic.
Mm-hmm.
So could you bill it as a group? Could you build this is a family?
Maybe if they were all maybe that would be a workaround if they were all participants.
Yeah,
Maybe.
I mean,
Yeah,
one
that'd
would be the codependent, the other one's
that'd be something to look into for sure. Yeah, and I think that is like one of the most challenging parts of the conversation. I didn't know about the collateral code, so yeah.
Just on that same question is that developing this type of thing.
Mm-hmm.
Sometimes things don't exist, but you want to move into them existing because they would be beneficial. The ways you're talking about.
Yeah, and there may be some stuff like around the new community health worker CPT codes that you may be able to use that are like new. My organization is looking at those and trying to figure out if it is something where we can incorporate families and, it's not a huge reimbursement, but it'd be something. And so some question marks around that. Yeah.
So first and foremost, thank you for your presentation. Because I'm walking away, I've learned a few things to expound upon my own personal passion to help those that are suffering from the disease of addiction.
Mm-hmm.
So first and foremost, the dynamics of the family. I mean, as I look throughout my life growing up here in the state of California, you know, and I've traveled, I've lived elsewhere, but it's everywhere, addiction worldwide. But, you know, to focus in on the space, the environment that I get to work in and, you know, to promote wellness and recovery. I work for DMH. And so I work with the most severe chronic, those that are mentally ill. And a lot of times there is no family. There's no family support. They burnt every bridge imaginable. So it's difficult, but at the same time, I'm grateful. Like I want to really hone in on this gratitude, because it is about building healthy relationships in our world today. As I'm so thankful to be here present face to face with all my colleagues. And, you know, but the fact is support systems without someone in delving into recovery, maybe for the first time, without that family support or that support system in place, I beg to say that it will not look as the positive outcome I'm not as hopeful for. But with that support system in place, and a lot of times when I'm working with individuals along with families, I let them know my whole immediate goal at this time is that I need and want you to feel that support.
Mhm.
You know, most important now, I need you to walk out of here today. When you do, when you leave these doors, I want you to feel and embraced for that support. And it's a human condition. Our communities are suffering. The fentanyl, it's no joke. And the other illicit drug usages. I mean, rumor has it that they're putting fentanyl in everything.
Yeah, that's not a rumor. Yeah, that's the truth.
Know that, but thank you for your raising my own awareness about just how grateful, you know, we can rebuild. I mean, you know, that I think rebuilding is essential. Our systems in place, back to racial disparities. But nonetheless, we do have a shortage of staff. So my question finally, on a you know, my name is Gail Salzer. I'm going to get a little political, but it has to be political. We have to raise the awareness at the government federal level to procure more funding to again rebuild the families and communities in every county throughout the nation, and hopefully that when we do, it'll spill over worldwide, because I know that it's important that we change as a humanity and not just change the country.
I have a programmatic question. So the Family Fridays, so
Mhm.
how is that, so who runs those, who participates in them? How do you get families? I have a lot of clients, adult clients who have ended up because of substance use disorders, having to move back home with parents, and oftentimes it can be like this, like very, it can like kind of recreate that child-parent dynamic that creates a lot of like, you know, that is re-triggering clients all the time. So I'd like to integrate families more. So how do you, can you tell me a little bit more about what that looks like?
Yeah. So that I think is probably the most like common scenario, the one that you just described. Person using drugs gets an opportunity to be back with their family. Family's trying to help them. Family doesn't understand what's going on. They're already seeing us. Participant has already seen us. Individual counseling or group counseling, we're connecting, and the subject comes up of my family doesn't understand this, or my family is saying this, or my family is saying that. And what we say is, well, if you would like your family to understand the evidence and what we do here and be able to, this is what we're going to talk about. And part of it's going to be about having family boundaries and those kinds of things, and the importance of healthy family boundaries. And are you open to that? That might be part of it, right? And then creating that space of like every Friday from 1 to 3 is a space at CARES for families to come and participate.
And so the families sign up, and then you know who's coming. It's just one family at a time.
One family at a time.
And who's facilitating? Just, okay. And do the medical providers facilitate it all, or give any? Or just
Usually it's just a counselor, and usually it's me at my location. If there are like really heavy duty medication questions, usually like the overview of like, hey, this is the evidence around buprenorphine, or this is the evidence around Vivitrol or naltrexone or whatever, right? I think I've yet to have a family member say, and I always say, I'm not a doctor, so I can't say what's going to be prescribed or anything like that, but this is what I know about this. And usually that's like, they're good with that, especially when you start looking at like evidence of opioid use disorder. Here's what it looks like without medication. Here's what it looks like with medication. Here's the argument against replacing one for the other. And connecting with people in a way where they're like, I got something of value out of that. I feel like I can call and talk to Josh. And then we say, if you want to come back, we'll create the space for you again. And it seems to really help our participants.
And is the client there with the family, or is it just the family? Is it like something that they're all participating
That
in?
depends
Okay.
on the participant. Sometimes the participant will say, here's my family dynamic. I want to be a part of it. Other times we'll be like, Mom and Dad need to know about this, but I don't want to be in there with them. right? And so let them be the driver of that. That's what we do, is we let them be the driver of that.
Yeah, if I could ask a question. I think your concept of hope is really critical, especially when there's no family connection, right? That hope speech, that hope language, that whole hope concept has to be an integral part of the way we try to engage the family treatment. And I really appreciate that. And I just wanted to commend you on that. Now, I got two questions. In regards to these sets that essentially rolls out, sometimes they're not culturally controlled. And one of the things that I heard was, your brief comment about being culturally responsive. Now, I work within the indigenous community and the Native community, and I find that oftentimes, the concepts that matter and the methodology that matters to Native people are not really considered. I'm talking about the medicine wheel, the white bison model, the other models that exist within Native treatment. And we know the impact of the historical traumatic impact, the institutional impact on Native families has been something that has still not been resolved, and still the trauma exists because they've been disconnected from their family, they've been taken away from their families. So I think one of the things that I like for you to consider in responding to my question, if I could get to it, is that fact. And then also the whole billing aspect of providing peer services, where you have different medical codes, right, that are going to be rolling out very soon.
Yeah.
It's going to be helpful
Yeah.
in regards to engaging and bringing families in, because I know in the indigenous community and in the Latinx and the BIPOC community, it is something that that is not, it's something that is a real critical need to get family involved, because I know for me as a person of mixed heritage, a person from the first contact people, and then being brought into this wilderness after being displaced is something that I'm still recovering from. But I have that sensitivity to be able to recognize that the indigenous cultures and communities, I thought I turned it off, has not been addressed. So, and so I just want to provide you additional hope. The SB 803 certification and that whole billing cycle and recovery-based services gonna be critical for your youth.
Right.
So, so two things. One of the things that we do every time where we have family members come is we really show the part of we do recover, and we show the science behind that, what that looks like in the brain, what that recovery process looks like in the brain, and really giving people hope. And then also we do this thing where I always like to ask people, well, tell me what a diet is, right? A plan to improve your health and wellness around food, right? And how many different diets are there?
A lot.
A billion, trillion, million, right? Right. And then I compare that to recovery. Well, what's recovery? A plan to improve your health and wellness around substance use. And just like a diet, there's a lot of different ways for that to happen. And really, really respecting people of, hey, if your way is different than what my way looked like, awesome, who cares, right? And really, really being able to respect people's right to guide their own lives in their own ways.
Yeah, just building on what you said, so I was just wondering, and I do work in a Native community, and family is really important to Native Americans, right? And so just thinking like in historical and generational context, like this works with if you have safe connections or safe people, right? And like a lot of Native families, like intergenerationally, they're suffering from addiction and traumas. And so what do you do to support that individual that doesn't have those connections or those safety within their relationships?
That's a good question. I think people can create recovery capital lots of different ways, and that when we're talking about like different populations of people is really like being more than just like culturally responsive, but like trying to take it to that next level and understanding that, not long ago, Native people were being taken from their home and forced to go to boarding schools, and recognizing that is a thing that their elders may look at me and say, hey, that is a person that did that to us. And so really, really being aware that that's a thing, and not being afraid to have that hard conversation, and not be afraid to address those disparities and look at them.
And is it like, so your psychoeducational model, is it just derivative of addiction, or do you go into a little bit deeper, like of understanding family structures that are dysfunctional?
Yeah. So we'll talk about like the ways to make boundaries and codependency and those kinds of like, family dysfunction and the roles and all of like, the roles that dysfunctional families might have. And we'll talk about those things. And to be transparent, my community is primarily white people. And so, that cultural challenge presents itself sometimes to us, but it might not be as predominant as, say, your work environment. And so, but I think that we have to have the courage to have those conversations and to look at those things so that we can drive positive change around those things.
For sure. I think I was just looking at the dysfunction and how do you bring the dysfunction in safely to help heal the person that's trying to move forward.
Yeah, and so I think really when we're getting there is really like using motivational interviewing and also really looking at cognitive behavioral interventions around your thoughts, feelings, and beliefs and how things may have been thrust upon you that aren't really your belief, right? Like, let's say if I'm having thoughts and feelings that are changing all the time, but let's say as a kid I was cruising around and I was with my dad and he said, watch out, son, people that drink purified drinking water are lunch stealers.
Yeah, right.
Right? And I'm like, oh, I didn't know that. Right. And I'm out with him again, and the next time he says, watch out, son, all people that drink purified drinking water are gonna try to steal your lunch. And then that becomes a belief that was thrust upon me, right? Are you gonna try to steal my lunch? Oh, what an opportunity for me to look at that and say, where did that come from? Do I want to hang on to this belief or not? Right? And look at the things that were created for us and decide, do we want to hang on to these things or do we want to do something different? And almost always those beliefs, positive and negative, are created from that family structure. Yeah.
Also, sometimes for as well, and I think sometimes for some of our patients, helping them understand that they really are only responsible for themselves. Like we can come in and sit down and talk, and I can, have your back and explain all this to them, but really helping them walk with that understanding that they are only responsible for themselves. You can't change someone from you, can support them. And sometimes even just being there to be that person that the family has to now call me 900 times, they'd be like, Brianna, I have this question, that question. So they're not hounding their relatives and probably just trying day by day to just make it and continue and, do great things and not be, continually like this person. So just sometimes be the barrier for your patient. You might not change their whole family dynamic and it might not be all sunshine and rainbows, but you might be that person that can now be a go-to point for their family to voice their concerns. And even if it just releases that little bit of tension off of that person's back, it can change the dynamic of things. And it might not, it might not be the model that you envision, but you still make a change in their life. And we've seen that a lot. Having contact person.
I think one of the things is to not envision a model. right? To not be like, this is what a family should look like, right? Really great point though of the thing of like helping people understand what they have power over and don't have power over. I also think that improving family relationships can be motivating for people to improve their health and wellness. Anyway, good comment, really great comment. Yeah.
There's an amazing where in Santa Cruz, there are like organization that I work for. We do what's called Celebrating Families. I don't know if anyone's heard of that model. It's a heavy lift, but there's like family role plays that you get to participate in. It's a breath of fresh air now that we're having families back in person, but it's a great model to look to. It has a lot of culturally sensitive role plays and techniques that have kind of come a little bit further into the 21st century as it relates to cultural sensitivity. But yeah, I was just thinking about.
Did you say it's called Celebrating Families?
It's an evidence-based practice called Celebrating Families.
Nice, nice. I'm gonna look at that. Awesome.
Yeah.
Thank you.
It also incorporates small children. 0 to 5 population in the model. So you can bring them into the room and still have a conversation about how they've been affected by their family's use. I don't know. I love celebrating families. So and then, the collateral, I think the collateral code from Medicalis.
So I
We've been trying to do it.
Yeah.
Just last, my question to you, I feel like it's a deep question for anyone to have to answer. The sandwich effect, under harm reduction. So I'm asking you, I want to hear from you. What is your opinion? And I know it's always individual and, linear to the individual, but methadone and there was another drug.
Buprenorphine.
Yeah. So how long should a person stay on?
Well, that's a good question.
Asking the wrong question.
No, I think that's a fair question. And so I think the answer to that question is, how long should a diabetic be on insulin?
Ooh.
How long should a type 2 diabetic be on insulin?
Oh my God. Okay, I'm gonna stop.
Part of my own story is that when I first started pursuing recovery, my relationship with food got a little wonky, and I had type 2 diabetes.
Yeah.
And I was insulin dependent for 8 years. And then I decided I'm gonna change this too, and I lost a whole bunch of weight and did all this stuff, and now I'm not on insulin, right? because it's no longer something that is needed in my life. But if it was, I would be. And no one would ask me, how long should I be on that medication?
I'm out of here. I'm leaving.
Right? As long as it's a benefit to the disease process, right?
Yeah.
Yeah.
Thank you.
Yeah.
You know, you just saved my life.
I have one really great success story that just happened just recently. So we were presenting, and you know, substance use is often a family affair, and one of the family members, a mom, came and talked to me after and like pulled me aside. And I was like super thankful and all this, you know, all that stuff. We're like, okay, yeah, great, right? You hear that. But what she said that was super meaningful was, my brother died from alcohol use. And I know that he loved his family, and I could never understand why he couldn't stop drinking. And now I know why, and now I have closure on that. And her brother had died like 10 years before coming to see us. And so that was just like one of those powerful moments of like, wow, when we help people understand the why of things, right? It can be healing and create hope.
Yes.
We'll actually cap it there because we are about to end for our both lunch and lunch keynote. So I just want to thank Josh for.
Thank you. Thanks.